السلام عليكم. محاضرتنا اليوم إن شاء الله راح تكون عن two diseases important in otolaryngology, and these are the intrinsic rhinitis and nasal polyps. The objectives are to differentiate the types of intrinsic rhinitis and also to differentiate types of nasal polyps. Intrinsic rhinitis. Intrinsic rhinitis احنا مثل ما قلنا احنا عندنا 3 types of rhinitis, 3 important types. either infective rhinitis اللي مثلها common cold, allergic rhinitis اللي حكينا عليها بالمحاضرة السابقة, والintrinsic rhinitis. Intrinsic rhinitis, it is non-allergic and non-infective inflammation of the nasal mucosa, which is characterized by nasal obstruction, rhinorrhea, and hyposmia. Actually it is divided in 2 types, either eosinophilic and non-eosinophilic. طبعا هذا التقسيم eosinophilic non-eosinophilic يعتمد على انه بالباثولوجي if the eosinophils constitute 25% of the cells, it is considered as eosinophilic intrinsic rhinitis, and if it is less than 25% of the cells, it is considered as non-eosinophilic. طبعا اسم الآخر للانترنسيك راينايتس هو الفازوموتور راينايتس أو الإيديوباثيك راينايتس. يعني actually there is no well defined underlying cause. So as there is no clear underlying cause, there are predisposing factors, which are many predisposing factors. The most important one is the upset of the autonomic nervous system. This means that in certain cases there will be imbalance between the sympathetic and parasympathetic system. And as this imbalance of the sympathetic and parasympathetic system which supply the nose, this will lead to the disturbances which lead to intrinsic rhinitis. So it will be seen in certain patients who with disturbances in the sympathetic parasympathetic system, such as in those in pregnant patients. Other predisposed factors could be familial tendency, could be immunological abnormalities, psychological upset, endocrine. So it is seen in more in puberty and during menstruation and in pregnancy. Drugs may play a role, such as beta blockers and contraceptive pills. Pollution such as smoking, atmospheric conditions such as change in the humidity and change in temperature, so that this type of rhinitis occur when the patient come from a hot area to a cold area suddenly, or vice versa. Also alcohol may play a role. As we said, these are predisposing factors, but actually there is no well-defined cause. Clinically, the eosinophilic and non-eosinophilic rhinitis, regarding the nasal obstruction, it will be moderate to severe in eosinophilic rhinitis, but is mild in non-eosinophilic rhinitis. Regarding rhinorrhea, it could be mild to moderate in eosinophilic rhinitis, but it is severe in non-eosinophilic rhinitis. Sneezing apparatus, minimal in both. Hyposmia, it is usual in eosinophilic rhinitis and rare in non-eosinophilic rhinitis. This is because in eosinophilic rhinitis, as we see, there is more nasal obstruction, and this nasal obstruction will prevent the odorant molecule from reaching the olfactory area in the roof of the nose, and so the hyposmia will be more common in eosinophilic than in non-eosinophilic rhinitis. Inferior turbinate hypertrophy, also there is more on nasal obstruction eosinophilic rhinitis, so the inferior turbinate hypertrophy will be marked in eosinophilic rhinitis but is mild in non-eosinophilic rhinitis. Polyps also and sinus mucosal thickening, it will be more common in eosinophilic rhinitis, but the polyp never occur in non-eosinophilic rhinitis, and the sinus mucosal thickening will be rare in non-eosinophilic rhinitis. So in non-eosinophilic rhinitis, the most important feature is the rhinorrhea, while in eosinophilic rhinitis, the most important feature is the nasal obstruction and the pathological changes which cause the nasal obstruction, such as the inferior turbinate hypertrophy, sinus mucosal thickening, and nasal polyps, which will lead also to more severe hyposmia in eosinophilic rhinitis than in non-eosinophilic rhinitis. Actually, for investigation also it is of clinical diagnosis, and actually it is diagnosis of exclusion. So we can do IgE estimation by press or rust test and skin testing to exclude the allergic rhinitis. CT scan of the nose and paranasal sinuses to exclude structural abnormalities such as the septal deviation and concha ballosa. All these will cause nasal obstruction, so that by CT scan there will be apparent. The treatment of idiopathic rhinitis include medical and surgical treatment. Actually, the medical treatment, it is largely similar to the treatment of the allergic rhinitis. Include steroid treatment, could be topical and short systemic course, such as bisonide, topical, and prednisolone short systemic course, 20 milligram per day for 5 to 7 days. Antihistamines such as disloratidine, topical ipratropium bromide to decrease rhinorrhea, so it will be very effective in non-eosinophilic rhinitis. Systemic sympathomimic drugs such as pseudoephedrine, and topical sympathomimic drugs such as xylometazoline. This is to treat the nasal obstruction, which is very useful, especially in eosinophilic rhinitis. The surgical treatment include treatment of the associated conditions, such as if the patient develop polyp or sinusitis, we may need endoscopic sinus surgery. Turbinate surgery like submucosal diathermy, which will cause, by diathermy of the inferior turbinate, will cause fibrosis of the submucosa, and this will lead to decrease shrinkage of the size of the turbinate. Or autofracture of the turbinate, the turbinate will be pushed more laterally to decrease the nasal obstruction. And turbinoplasty or turbinectomy, which is removal of part of the inferior turbinate to decrease the size of the inferior turbinate and improve the nasal obstruction. Videoneurectomy, which is a nerve containing parasympathetic fibers which cause the rhinorrhea, so that by cutting off this nerve will decrease rhinorrhea, so it is especially useful for non-eosinophilic rhinitis. And now we come to another disease, the second topic in this lecture, which is the nasal polyps. Nasal polyps are defined as abnormal pedunculated lesion due to the oedematic mucosa in the nasal cavity. The polyps of three types. The nasal polyps is associated with the chronic rhinosinusitis, which is the commonest type, and its other name previously named as simple nasal polyp. The enterochoanal polyp, it is a special polyp, will be discussed later, and these both are benign polyps, while the third type is the neoplastic polyp, actually, which is a malignant polyp. Actually, it could be malignant polyp, and sometimes also could be benign polyp. But the important two, which we'll be discussing in this lecture, are the polyp associated with the chronic rhinosinusitis and the enterochoanal polyp. The neoplastic polyp will be discussed later on in the last lecture about the neoplasm of the nose and paranasal sinuses. It is important to note that there are some diseases can be associated with polyp. Asthma, which is the late onset asthma, not the atopic asthma. The late onset asthma is the most common condition associated with nasal polyp. About 10 to 15% of the patient with asthma have a nasal polyp. Also, aspirin hypersensitivity, which is called the Samter trait, present in about 10% of patients with polyp. So 10% of patients of polyp have allergy to aspirin. The aspirin trait, which is, as I said, it is the Samter trait. It is an association of nasal polyp with asthma and aspirin hypersensitivity. Cystic fibrosis, about 1/3 of the patients with cystic fibrosis have a nasal polyp. For this reason, the nasal polyp, when we find nasal polyp in patients less than 10 years of age, especially less than 10 years of age, because the polyp mainly a disease of adult, we have to exclude other conditions such as the cystic fibrosis. Allergic fungal sinusitis, one of the associated with nasal polyp, and actually it will we see by pathological examination it is fungal sinusitis, not a simple polyp. Cartigenous syndrome, which is called the immotile cilia syndrome, which is characterized by bronchiectasis, sinusitis with or without septus inversus, and infertility in male. And Young syndrome, which is in which there is the mucus will be abnormally very thick, and it is also characterized by bronchiectasis, sinusitis, and obstructive azoospermia, which lead to infertility. Clinical features of nasal polyp. The nasal polyp, as we said, mainly occurs in adult male and usually bilateral and multiple. This is for a nasal polyp associated with the chronic rhinosinusitis, which previously called the simple nasal polyp. May cause nasal obstruction, hyposmia or anosmia. This is actually because the polyp can obstruct the nose, nasal cavity, and prevent the odorant molecule from reaching the olfactory area and leading to hyposmia or anosmia. Facial discomfort, nasal discharge, and on examination by anterior rhinoscopy, there is a pale gelatinous swelling, and this is a pale because it is a poor blood supply. And when we see any mass inside the nose, we have to do palpation by probing. So when we palpate it by probe, we see that it is cystic and it is mobile and it is paleless because it is of poor nerve supply. And these features differentiate clinically the polyp, simple polyp or polyp associated with the chronic rhinosinusitis from the neoplastic polyp, and especially the malignant polyp. Nasal endoscopy is the key diagnostic tool. We can see the polyp, which, as we said, pale, gelatinous, and insensitive swellings. All these structures inside the nose will be very sensitive to probing and to touch, except the polyp. And so it is a very important feature that it is not sensitive to pain to diagnose the nasal polyp. Of course, with the other features we said. Most polyps arise from simple polyp arise from the anterior and posterior ethmoidal sinuses. So anterior ethmoidal polyp appear in the middle meatus because the opening of the anterior ethmoidal sinus is in the middle meatus. And if the polyp arises from the posterior ethmoidal sinus, so the polyp will appear in the nose from the superior meatus. This figure shows the nasal polyp, which is pale, gelatinous, and if we do probing, we see that is mobile and not sensitive to pain and cystic in consistency. CT scan. Actually, CT scan is indicated when the surgery is planned and when complications are suspected. So CT scan is needed if we plan to do surgery and if we suspect the occurrence of the complication of nasal polyp. It will show the sinus opacity, which is isodense lesion, and in severe cases will show the ethmoidal sinus widening in very severe and long-standing cases. And in allergic fungal sinusitis, will show the mixed density lesion of allergic mucin and bony erosion. So when we see a nasal polyp, simple nasal polyp or polyp that is associated with the chronic rhinosinusitis in CT scan, we see that it is isodense and there is no bone erosion. While if the polyp is associated with fungal sinusitis, we see that the polyp is not isodense but heterogeneous. This is because of the presence of the allergic mucin, and also we may see a bone erosion. And in MRI, actually, we see a pepper and salt appearance. This is also because of the presence of mucin. Important to know, as we mentioned, that simple nasal polyp is rare before 10 years of age. So if the polyp is found in children up to 2 years of age, we have to exclude meningoencephalocele by CT scan. And if the polyp is found in children between 2 and 10 years of age, we have to exclude the presence of cystic fibrosis by sweat test. Regarding the treatment, actually there is no surgical cure in the majority of the cases because the recurrence of the polyp is very common after surgery. Actually, the treatment includes medical and surgical treatment. The medical treatment includes the use of the corticosteroid, which is the most effective medical treatment, like topical steroid or systemic short course of systemic steroid. The topical steroid is used for 1 month, and short course systemic steroid also can be used even up to 3 weeks, but in tapering way. Antihistamine, topical decongestant. This is can be used to relieve the nasal obstruction. The surgical treatment of the nasal polyp, the surgical treatment of choice is by endoscopic sinus surgery, removal of the polyp endoscopically. And if it is not available, we can use simple polypectomy, or if sometimes the patient cannot withstand the general anesthesia. So sometimes simple polypectomy will be a good alternative, especially if the patient is old age and cannot withstand general surgery. So we can do it by under local anesthesia, and this is done by avulsion of the polyp by using tele-Hinckled forceps. We catch the forceps and we try to push it towards the nasopharynx and then withdraw it anteriorly from the nose. Now we come to the other type of the polyp, which is a special type of the polyp, which is the enterochoanal polyp, or what is called Guinean polyp. Actually, it is called enterochoanal polyp because it arises from the maxillary sinus, which is the anterum, and it will, when come from the maxillary anterum through the middle meatus to the nose, it will pass posteriorly towards the posterior choana, while in simple nasal polyp it will pass anteriorly in the nasal cavity. It is more common in adolescent male, while the simple polyp more common in the adult male, and it is almost always unilateral, while the simple polyp or the polyp associated with the chronic rhinosinusitis usually multiple and bilateral. But clinically it is the same appearance, translucent, pale and insensitive, but it is unilateral. And the simple polyp, as we said, from the middle meatus we see it in the anterior part of nasal cavity, while in enterochoanal polyp we see it passing in the posterior part of nasal cavity, and sometimes by anterior anoscopy difficult to be seen because it will pass to the posterior part of the nasal cavity. For the nasal discharge and nasal obstruction actually occurs in nasal enterochoanal polyp as in simple nasal polyp, but here it will be unilateral, not bilateral. And the patient notice that the nasal obstruction, which is greater on expiration than in inspiration, this is due to the ball valve effect. When the patient takes inspiration, the polyp will push posteriorly, and so the air can pass from the nose to the nasopharynx and down to the pharynx and to the larynx. During expiration, the jet of the air will push this polyp towards the posterior choana and close the posterior choana. So the obstruction will be more severe in expiration than in inspiration, which is called the ball valve effect. Pathologically, there must be no eosinophil, while in simple polyp there could be eosinophil, because in simple polyp one of the causes is the allergy. The diagnosis is by endoscopic examination. We can see the polyp, which is unilateral and arising from the maxillary sinus. Plain X-ray and CT scan, which shows the total unilateral opacity of the maxillary sinus. It has been postulated that the enterochoanal polyp is due to the faulty development of the maxillary sinus ostium, which is always large. In enterochoanal polyp, the maxillary ostium will be very large, while in simple polyp, the maxillary ostium is not large. And this is they explain this large maxillary ostium that it is a developmental abnormality. In simple polyp there is medical treatment, and if it failed we can change to surgical treatment. And in enterochoanal polyp there is no medical treatment because it is non-infective and non-allergic, and it should be treated surgically by endoscopic sinus surgery, which is called the S. This picture showing this is oral examination. By opening the mouth and tongue depressor, we can see that there is like a ball in the oropharynx. Actually, this is the enterochoanal polyp, which passes from the posterior part of the nose to the nasopharynx and reaching the oropharynx. We see that is not pale and translucent. This is because it is exposed to the air, and there is metaplasia of the epithelium of the polyp, and so it appears as pinkish color, and also as a result of the infection. This is CT scan axial view. We can see that there is the polyp unilateral arising from the maxillary sinus, and as we see, it passes posteriorly to the nasopharynx, and we can see there is a blackish area in the nasopharynx around the polyp, which means that the mass is not arising from the nasopharynx but arising from the nose and passing to the nasopharynx. Also, this is CT scan. We can see in this CT scan that there is total opacity of the maxillary sinus, and we can see that the maxillary ostium is very large, and the polyp passing to the ipsilateral nasal cavity and even pushing the septum to the other side. شكرا جزيلا، وإن شاء الله ألتقيكم بالمحاضرة القادمة.